Thank you for the introduction, and it's a real pleasure to be here and to be the host of this debate. I think this is a topic everybody who works in multiple sclerosis has been thinking about or is constantly thinking about, because essentially it addresses the very origin of the disease. Is this really an inflammatory disease in all patients? Is there an independent effect of neurodegeneration in some patients, or is there a combination of the two? I think that the two faculty that will debate this topic are outstanding, so I really hope you will stick around. These are my disclosures. I have no conflict of interest with the content of my presentation. Now, this is, of course, an autopsy of a brain of a patient who had multiple sclerosis for many, many decades, and this is really the end result of multiple sclerosis, where you have these large areas, mostly in the periventricular areas, of demyelination and axonal loss. You also see some of these areas in the cortex, but we really don't know how did it get to that point. Is this really just a burned out inflammatory lesion, or was there something first, some breakdown of myelin or axonal loss that triggered the initial event? Now, this is an active acute lesion of a very young person with multiple sclerosis, and you can see it looks like this. There's a blood vessel, a post-capillary venule, and in the perivascular area you have an infiltration of leukocytes, and I should really say we call it an acute active MS lesion. We really don't know that that's true. Most likely it's not, because we only see the patient when they have their first attack. And now, of course, there's an emerging natural history of patients with a radiologically isolated syndrome, so patients who really meet MRI diagnostic criteria for MS but never have a clinical event. And we know that these patients very likely have subclinical inflammations for many, many, many years before they first have a clinical attack and before we first look at their brains. So just to keep that in mind. Again, if you look at that active acute MS lesions, this is what you see with higher magnifications, and almost all of these perivascular cells are lymphocytes. Almost all of these cells are T cells and B cells. And the million-dollar question is, how did they get there? Because if you look at a controlled brain of somebody the same age with no multiple sclerosis, you don't see any lymphocytes at all. And there are two prevailing theories I think that you will hear about during the debate. One is the inside-out theory, which means that the initial event that leads eventually to multiple sclerosis occurs in the brain, that there's some breakdown of tissue, some demise of cells, that then somehow escapes into the peripheral circulation and somehow provokes an adaptive autoimmune response that then attracts peripheral cells into the brain at the spinal cord. Now, there's really, up to now, no biochemical evidence that, for instance, the myelin sheath between patients with MS and healthy individuals is any different. And also, the search for a pathogen that infects the brain or the spinal cord during active multiple sclerosis has really been negative so far. So I'm a little biased against the inside-outside theory, because in my view, up to now, there really has been a certain lack of evidence for this. And then the second theory is the outside-in theory, where the prevailing thought is that the initial event actually occurs in secondary lymphoid organs, where lymphocytes see an antigen that they recognize as non-self, as foreign. Typically, that's a pathogen. Those cells then become activated. They can go into any tissue in the body, including the brain and the spinal cord, and there they misinterpret a self-CNS autoantigen as a foreign antigen, and it's a classic case of autoimmunity, molecular mimicry. They now erroneously attack a self-autoantigen. This is relatively new evidence that was shown a year ago by Philip de Jager. It's data that he and a consortium of MS genetic centers have generated, and it shows 55 risk alleles for multiple sclerosis. There are more of these now, but I don't think I want to add all the new ones. They don't really add anything of substance to what I want to say. If you look at these risk alleles, there are three things I think that are worth mentioning. One, and as previous speaker already mentioned this, is that the odds ratio for all of them is very low. It's less than 2. So they are all minor risk factors for multiple sclerosis and very likely minor modifiers of existing disease. The host of the previous session also said something. He said, and I think he means what I'm about to say. He said multiple sclerosis is not an important disease. The prevalence is very low. I would say it differently. I would say that if you take MS and all autoimmune diseases together, they have no evolutionary impact. So they have absolutely no impact on population growth. Pathogens do. And that's the second thing that is interesting about these risk alleles. All of these risk alleles are very important in host defense against pathogens. And it is interesting that they are upregulated in patients with multiple sclerosis, because it means that at some stage this was a positive survival factor in people who had a lot of external pressure from different pathogens, and it helped them survive. And of course now that pressure is gone, but they still have a very active competent immune system, which now may pose them at an increased risk of developing autoimmunity. And the third thing that is very interesting here is that these are all, you can actually quantify the expression of these risk alleles with PCR methods, and this is actually shown here. And you can see that in the CNS, there's only a very low expression of these alleles, whereas in the immune-competent organs, secondary, tertiary, primary lymphoid organs, they are highly expressed. So when people look at these data, they say things like, this is interesting. David Hafler said this is really the only neurological disease that's located outside of the nervous system. And it's not conclusive evidence that MS is really triggered in the periphery, but I think it's a very strong argument, and I'm sure we can talk about this later. Now, there's one locus that actually has a pretty good odds ratio, and that's was also previously mentioned. It's on the short arm of chromosome 6. It's the HLA-DR locus, and this is an MHC class II molecule. And I think that's an interesting observation when you think about the origin of, or the etiology of multiple sclerosis, because this is the molecule, MHC class II or HLA-DR. In MS, it's HLA-DRB1-1501. It's expressed on a cell called an antigen-presenting cell. And the only function of this molecule is to present peptides to T cells with a T cell receptor specific for this peptide. So there's no reason a disease is associated with an HLR molecule or an MHC class II molecule if a CD4 T cell does not play a pathogenic role in this disease. And again, this would all argue for the outside-in hypothesis. And I'm only showing this, it's essentially the same slide. I'm only showing this because the B cell currently is the cellular target du jour in MS pharmacotherapy, but the B cell is actually a very potent and competent antigen-presenting cell that expresses MHC class II or HLA-DR to T cells, activates T cells, which then in turn cross-activate B cells and make them competent, potentially autoimmune-prone B cells. I think from all the treatment trials that we have done over the last decades, this is one that, again, is a good experiment to show that inflammation really contributes to neurodegeneration and disability. It's a drug called nadalizumab, and of course nadalizumab blocks alpha-4 integrin and prevents migration of cells from the periphery into the CNS. So what the drug really does is it compartmentalizes. It sequesters inflammatory cells out of the brain and the spinal cord back into the periphery. So you kind of have a chimeric patient with an attacked immune system, very active in the periphery, and no adaptive immune system in the central nervous system. And there was just recently a report that shows that patients who have been on nadalizumab for a long time really seem to have slower disease progression than controls, indicating, again, that inflammation is a contributing factor, and quite importantly, a very substantial contributing factor. This is data with fingolimod. Again, this is CSF data showing you that it essentially does the same thing in the end organ. It keeps cells to a lesser degree out of the brain and the spinal cord. And then, of course, Mark Friedman this morning talked about autologous hematopoietic stem cell transplant, which is really the most effective form of depleting the immune system and completely leaving the CNS alone. And so if it was really a CNS intrinsic effect, there would be no effect on disease progression if you do a bone marrow transplant in somebody with active disease. And that's really not what we see. So we actually see that this is a very effective therapy. This is from the NIH-sponsored phase 2 trial with autologous hematopoietic stem cell transplant in active MS. And you can see here that at 3 years, almost 80% of patients have no evidence of disease progression at all, including accumulation of disability. And this number worsens with time, and it's really directly associated with the reconstitution of the immune system. So again, I think if you look at all the pharmacological data, it would strongly argue that the two things are not independent of each other, but somehow related. Now, there are obviously different views to this, and I think you will hear more about this in a few minutes. Michael Barrett and John Prenius are strong proponents of a subtype of multiple sclerosis that is really completely independent of the adaptive immune system, that is really driven by apoptotic loss of oligodendrocyte and an activation of the CNS intrinsic innate immune system. They've published on this extensively. I'm only going to show you one publication which was published 13 years ago in the Annals of Neurology, where they looked at 7 patients with very newly diagnosed multiple sclerosis. The details are shown here, but you can see that some only had disease onset a few days, really, before biopsy material was obtained from them. And what they showed in all of these 7 patients was that there's an inactivated microglial cell. This is the nucleus of the microglial cell, chewing up apoptotic oligodendrocytes. And they saw this in all of their patients, and there was an abundance of this, and there was not one T cell and not one B cell in any of these areas. So they strongly argue that in some patients, even with early disease, there's an absence of a peripheral immune response. It's really seen as intrinsic process. Now, I want to caution you again, they looked at patients with active early disease. We don't know if that's really true. They looked at somebody here who may have had disease subclinically for many years or decades. Also, I always say this, and I think a lot of my colleagues don't like it, but histopathology is not a quantitative assay. It never is. You're looking at very few anatomical locations in the brain and the spinal cord, so it's always hard for me to interpret that. It's not quantitative. But this, I think, is a very good attempt of being at least semi-quantitative, if you will. Of course, this is work by Claudia Lucinetti and Wolfgang Bruck and other of her colleagues. This was published 17 years ago, and they looked at hundreds of autopsy and biopsy sections and developed these 4 histopathological patterns. And they showed in all of their patients and all their biopsy and autopsy material that there are actually monocytes in all of them, there are T cells in all of them, and there's one where you also have B cells. So this is the most prevalent one and also the one considered most inflammatory. This is another way of looking at this. This is pattern 2. I would call it again the most inflammatory. You can see that it's not only patients with relapsing remitting disease, but 75% of patients with secondary progressive disease and 50% of patients with primary progressive disease have this very inflammatory pattern that you see on histopathological sections. So only pattern 4 was considered an apoptotic neurodegenerative patterns, and you can see this only in PPMS patients and in fewer than 40% of them. So, and I really have to remind you that even in these patients, Lucinetti et al. Showed T cells and monocytes in tissue. So they didn't really have patients like the one that Barnett and Prenius have shown repeatedly in their observations. So I want to conclude that genetic data suggests an aberrant immune regulation underlying the pathogenesis of MS, and there are now many, many genes that have been identified. They all have low odd ratios, but they all appear to regulate lymphocyte activation and differentiation. Also, most patients with relapsing disease with early multiple sclerosis really do respond to immunoactive therapies. And the stronger the immunosuppression that is applied, really the most beneficial clinical and paraclinical outcomes we see. There seem to be cases with relapse and remitting a disease where there's no histopathological evidence of lymphocyte involvement, as I have just shown you. And this may really represent a subtype of MS with a primarily neurodegenerative phenotype. This is, I think, something that needs to be studied more extensively. So with that, I want to move on to the debates and have the first debater up here. Okay. Yes. Thank you.
Thank you very much, Professor Stuve.